Thank you very much. So that moves us straight into our next panel. So I'd like to invite on to stage, please, Christopher Fern, Deputy Prime Minister and Minister for Health in Malta, Dolores Montserrat, MEP, Nicoletta Lupi, Managing Director, MSD Italy, and Catherine Elliott, Director of Research and Partnerships, Cancer Research UK. Please take any seat you like, sir. It is. There we go.
Okay, yes, tomorrow.
So you have the honor of the first panel. The way all these panels are going to work is I'm sort of going to ask some opening questions and ask for a few opening remarks, maybe 3 or 4 minutes each, and then it's over to open discussion. I'll always have questions up my sleeve, but you've probably heard enough from me, so I want questions from you. And let's have a rich debate and discussion. I want to go first to Dolores. I think, Dolores, I'm going to move from the European to the sort of local. So first, Dolores, the European Beating Cancer Plan is...
No, it's the screen, no?
Is it the screen? Okay. I
So.
just want to make sure
so.
it wasn't this fire alarm that's not expected. Okay. Right, so in the framework, there's this new European Union of Health, and within that, the Beating Cancer Plan has to fit within that. So perhaps you could talk a little bit about that relationship and what European Parliament is doing to encourage and implement the European Beating Cancer Plan across the continent.
Okay, yes. Thank you very much to invite me to be here with some friends and, presently, because all the time we did in a screen and, and on digital, so it's a pleasure to be here presently in Brussels. First of all, I want to start to say that now we start a health decade here in Europe, and it's a big opportunity for all of us, not just for the patients, for all the stakeholders, and of course for all the 3 levels administration, so European, national, and regional levels of the administration. Why? Because the COVID gave us a lot of lessons, and I think so that these lessons, we take it, and now we're going to push for a really European Union for Health. We have the European Union bankery, finance, the euro, so the freedoms, the 4 movements of freedom. So now we have a big opportunity building the European Union for Health. And inside of the European Union for Health, we have a lot of tools. But in all the European Union for Health, what we are doing, putting the patients in the center of our policies. Second, to have a resilient and a strong and competitiveness industry and innovation and research. And the third point, for me, very important, to maintain and to defend the sustainability of our health public systems. Because, in Europe, we are so different. We are so different of China and the United States. They don't have universal health. We have it in our 27 countries, and we want to maintain that. So what we want patients, resilient and a strong industry and a strong administration, 3 levels, and then sustainably, we want to have our public universal health in the 27 countries, and we need to protect the sustainability of this. So the plan, the Beating Cancer Plan, we start before the COVID, but it's true that we finish after the COVID, during the COVID. So this is the reason that it is a big opportunity. We put in the European Union for Health a lot of tools that we have to use it. For example, I'm thinking with the health data space. Commissioner Kyriakides, she was talking about that. For us, it's very important because we have to think that we need all the precision medicine, high-performance computing, a common European Union health data space, genomics, and artificial intelligence, because all essentials for a more equitable access to innovative and effective medicines and treatments against cancer. So we cannot forget that science, that technology are our main allies in the fight against the threats to health we are facing. So for me, it's important to put the Beating Cancer Plan inside of the European Union for health, and then sharing with all these big tools. It's just not the European Health Data Space, but we have the EC proposal for a new council recommendation on cancer screening, the reinforcement of the ECDC and the EMA, the European Union Health Program. It's the first time that we have our own health program in the European Union with more autonomy, 10 times more budget than before when we were trying to find different programs in the different funds in Europe. Then we have the mission cancer of the Horizon Europe. It's the first time that the 5 missions that has the Horizon program, one is health and it is cancer. And then, of course, the pharmaceutical strategy for Europe. So I think so that all these tools gives us a big opportunity in this new decade that all of us, we have a big opportunity to give the best health to the patients. So I think, and I'm finishing, I think that prevention, we can talk all the time, but prevention, early diagnosis, access to the best treatments, it is so important with innovation. We need the innovation. We need to protect, of course, the IP, and of course that after the IP, we have to have biosimilars and generics, of course, because, it's 2 steps difference and 2 times difference. And the 4th point, for me, important in the Beating Cancer Plan, it is all this support, the social, economic, finance support to the families, because the families during the European Beating Cancer Plan, they were asking us, okay, the best treatments, the best access for everybody, the best quick diagnosis, early diagnosis, but we need help on taxes, for example, because it's not the same to live in the Pyrenees or live in Madrid, Barcelona, big cities with the big hospitals. A family that comes in cancer and they are living 200 kilometers from a big hospital, they have more cost. And we have to help them, not just with economic, social impact to them. Of course, we have to help them. Labor measures too, because the survivors, we have to help them to go in again to the labor access. So I think so that it's an incredible plan, but now we need all the ministers of health that they have to implement in the 27 countries. Taking the last words of Kyriakides, let's do it together. I think so that we can do it. The stakeholders, the 3 levels of the administrations, and all the patients.
Thank you. Okay, well, that's the question to you. I'm really interested, I suppose, building on what Dolores has said around how you are innovating the cancer systems in Malta and how it's as an example of a member state and what you're doing and how that relates to what's happening at the European level.
Well, Dolores was a minister herself.
Yes, with you. We joined that time together.
We shared this. Okay, so I just want to use my 3 minutes to share an idea which is working in Malta. I don't know whether you'd call this best practice or not, but it's a practice and it's making a big difference. You very rightly started the introduction to these 2 days by saying that, by defining excellence and saying excellence in cancer care is not just or solely survivorship, but you said patient outcomes, so how patients go through this. And this is an important point because when I discuss efficiency and effectiveness of treatments with colleagues, oncologists, public health doctors, people say survivorship has improved by 2%, by 6 months, and they take that as the definition of how effective a drug is, or a medicine is, or a treatment is. And the oncologists are even happier, and they say we have complete success if the patient dies of something else. So they tell you our treatment was really successful because the patient died of something unrelated. For the patient, that's not a very good outcome because the patient died. But this is how we define, and this is flawed. Because you are right, if somebody is living for 10 years, for 50 years, or for 6 months, they want to live a good life, and as good as life as and having less anxiety, and having a better mental health is an extremely important part of it. And of course, some of you in the audience here are cancer patients and cancer survivors. You will know that as soon as the word cancer is mentioned, then You start a new life. Your levels of anxiety go overboard, and you feel lost. It's a big journey. You have to see oncologists, physicians, surgeons. You do I don't know how many tests a week or a month, and it's a big, complicated journey. And there's a lot of anxiety that you might not be getting the best treatment, or that you might be missing appointments, or that you might need to be doing something that you're not doing. And this makes a big difference. And people are lost within the system. They should have an appointment, but because they've been asked to see somebody at the same time that they've been told that their cancer has taken a turn for the worse, they forget everything that they've been told, except that there's something happening in their life. So what we've set up over the last 5 or 6 years in Malta is something called nurse navigators. It's not a new concept. There are some other institutes that do it. We're doing it nationally, on a national level. So we have, and this is really, really inexpensive, and it's quite straightforward. So we have nurses who are trained, and they specialize in one particular cancer. So not just one cancer, but so colorectal, head and neck, breast, urology, lung, etc. And as soon as the word cancer is mentioned to a patient, they are put, at the beginning of the journey, they are put in contact with this nurse specialist, who is a nurse called a nurse navigator, who goes to their home, is available 24 hours a day. And one patient has at most 2. So there are 2 nurses who are on roster. So there's somebody that they know 24 hours a day. And they lead them through the system. So they organize their appointments, they organize meetings with surgeons, they tell them who the best oncologist for the particular disease is, what to expect when they start treatment, whether their hair will fall out or not. If the hair is going to fall out, what they might need to do to make that easier. So they make the life of the patient so much more certain during the whole journey. It decreases time from presentation to diagnosis significantly, and from presentation to treatment significantly, because, as I say, people get access quicker to specialists, and they don't miss appointments as much as they would otherwise. But most of all, it gives patients a focal point, a reference point, and they know that they are on the right path, and they know that there is somebody always doing the worrying for them. And this has made an incredible amount, an incredible difference. It's such a simple thing to do. Nurse navigators, they are just full-time, these nurses full-time, looking after patients to go through the process. And when you ask patients who in the process or after, or survivors, what was the thing that made the most difference in your treatment, they will say, these nurse navigators, they are so important to us, they are so fantastic, they come to our home, they are available 24 hours a day, they are inexpensive compared to getting a new MR Linac. Paying a nurse a salary is peanuts. But they make a very, very big difference. And I don't know why it's not done universally everywhere. We've started this about 5-6 years ago. It's been a tremendous success. And if there's one point that you can take out of this from me is this. Try them out, nurse navigators, and they really work.
Fantastic. So what I've heard so far is Dolores painted a broad picture of European aspiration and an EU toolkit that member states, a developing toolkit that member states can plug into. And Christopher, you've described a sort of holistic concept of excellence. And also, I think what's interesting, I mean, you pointed to this specific example, but that innovation goes beyond what we might traditionally think of as innovation, biotechnology, but it also goes to service innovations, which can deliver huge benefit in the form of nurse navigators in this case. I want to now, we're trotting through a lot of areas, but that's good. We will be exploring them in more detail through the next session. So bear with us as we kind of do this gallop through all these broad areas. Catherine, let's talk about research and how research feeds into this concept of well, obviously innovation, but how it contributes to equity and excellence as well, and particularly in your work with Cancer Research UK, the largest charity funder of research, is that right, in the world? Yeah. Okay. Please, yes.
That's all right.
Is the microphone on?
So, yes, as you said, we're the largest funder research in the world at cancer research.
Could you switch the mic on?
Yeah, the micro.
Maybe I shout.
That's better.
Thank you. So for the next 5 years, we will fund about £1.5 billion sterling of cancer research. And all of our funding is from public donations. We don't receive any government or private sector funding. Our aim, like everybody here, I think, is to ensure that everyone can live a life free of the fear of cancer. And I think importantly in this context is to think about what that means, everyone, not just selected groups. And at the heart of our strategy is to ensure that we bring science right through into prevention.
Could we maybe we could have a handheld? Would that be okay, just for this session? Thank you. Just while we try and sort this problem. So sorry, Catherine. Can we just use this one? There we go.
Yeah, sure.
Yeah.
Maybe I just take this off.
Thank you so much. Right. Apologies.
Thank you. Yes, that's better. So as I said, our strategy is to fund research across the pipeline from early discovery science, whether that's wet laboratory, data research, right through into innovation in prevention, detection, and treatment of cancer. And we fund that through a network of research institutes, centres, clinical trials, and large, what we call response mode programs and trials. And key to all of that is working in partnership, and that's why I am delighted to be here. I'm happy to say that over 30% of the clinical trials we fund have at least one European partner, and we've just relaunched our Cancer Grand Challenges scheme, again with European charity partners, and that's critical. Cancer research is global, innovation is global, and wherever we are geographically, whatever our politics, we have to partner and work together to do this together. So thinking specifically about inequalities and what's the role of a research funder, in the UK, we have equally stark inequalities, some to do with ethnicity, with gender, and particularly socioeconomic deprivation, the same as you've talked about in Europe. So at least 5% of cancers are additional cancers because of deprivation. And that links to a lot of different factors in terms of the incidence of cancer. The Cancer Control Plan talks a lot about prevention, tobacco control, obesity, increasing the air pollution, climate we need to think about, but also access to screening, uptake of early detection, and in fact access to treatment and treatment people receive. So we see the same issues and we need to tackle those. In terms of research funding, I think what we sort of do and what we focus on partly is to understand those differences. And again, we've heard about the European databases, the inequality databases. It is so important to capture and understand what the differences are, and then to go back into our research pipeline and understand where those differences are coming from. In some cancers like prostate cancer, they may be really marked ethnic differences because of genetics. In other areas like lung cancer, there are marked differences because of the atmosphere, because of smoking, lack of prevention strategies implementation. So we need to understand the differences, and then we need to make sure that the research we fund addresses those and brings them up to levels up, if you like, and certainly does not exacerbate or perpetuate those inequalities. So we need to make sure that the design of research, the participation in clinical trials, the samples we collect and analyse, so the innovations that come through will be applicable to all populations. Going a bit deeper into that, how do we do that? One, I think, is to work really closely with underserved communities. Not assume that we know what people need. We did a nice study recently, which you may have seen, of self-sampling for cervical cancer, so women can take their own samples, and that makes a huge difference to some groups of people who either culturally or for their own sort of social or psychological reasons find cervical screening very difficult to access, so self-sampling might make a big difference. So working with communities to really understand and not assume that we know what the issues are. I think another really important area we haven't touched on yet is the workforce. Our research workforce in the UK, I think also in Europe and in the US, is not diverse. So we've invested in scholarships for students, for black students to take up PhDs. We do a lot of work in schools and in universities to encourage students from ethnic minorities to move into research, because again, if our senior research leadership is not diverse, then we are not thinking about these issues and implementing them into the research we fund. And as I say, finally, just to re-emphasize the importance of working, I think, with people, with patients and the communities, to make sure that we're hearing their voice through all of this. And then working closely, and again, in partnership, to make sure that the implementation of these innovations is done in an equitable way, and that we really address those inequalities that we see in the diagnosis and treatment of cancer. So that's a very, again, rapid gallop through. I'm happy to talk about any of those parts further, but thank you for the chance to touch on those.
Thank you, Kathleen. I mean, that's really interesting because it's easy to put the equity thing just as an implementation issue. That we know we've done the research and now we just need to implement it equitably. But you're saying that equity begins in terms of research workforce and research methods, and then we extend it from there. So thank you. Right, Nicoletta. You're representing MSD industry here. What do you see as industry's responsibilities in regard to this concept? Well, obviously, innovation is what industry has traditionally been known for, innovation in biotechnology, but in terms of equity and excellence as well. And how are you interacting with the European Beating Cancer Plan or responding to it?
Thank you for the... Can you hear me?
Yes.
So thank you for the question. Thank you for having invited me, and it's really an honor to be part of this panel. I think collecting also the different inputs we have received so far, I think we should start with what we have today and what we don't have today, and then I can move on with what can the industry do to play our part, to be part of the solution. So we have learned that we can really have, starting from research, amazing opportunities. We are truly living an age of renaissance with regards to research, especially in cancers, both from prevention, but also as far as treatment is concerned. Why am I referring to prevention? Because we can also count on vaccines that can prevent cancers. We have hepatitis B vaccine. We have HPV papillomavirus vaccine that can really be the greatest gift for humanity in order to not only prevent but eliminate certain types of cancers. And this is already part of the European Beating Cancer Plan. And it's an opportunity we cannot miss. And there are precise targets, 90% of adolescents that should be vaccinated by 2030. This is the opportunity, and in this we have an opportunity to really prevent all these cancers in every single country of the European Union. But as a matter of fact, we are also living with another truth, and the truth is that we don't share common data. Usually, when I attend congresses, we always start from projecting data. That's an habit, and it's a good habit. But to this extent that we are discussing today, we could only compare apples with pears, because we have different data coming from different countries, and I'm representing also not only MSD Italy, but I mean the data that are typical of Italy as a country, and we have regional data, believe it or not. And the other problem that we are facing is that whenever we have data, provided that we can compare these data, but then these data they always come too late. And one of the other biggest opportunity that we have right now, and I think that COVID-19 has been one of the amazing lessons we have learned, is the digital opportunity. The digital opportunity is also the money that the European Union is putting in place so that every country can invest in the digital opportunity to have in-time, real-time data that can be compared and should be interoperable data if we really want to move together, but faster. So that's why as MSD, what we can do as an MSD to improve all this. And I mean, whenever we're referring to data, we are not only referring to the opportunity of having data about screening, about diagnosis, but also about treatment and about coverage rates. as far as vaccines are concerned. And it's very important that the electronic record of VCR should be available for all vaccinations, for all citizens across the entire lifespan, because that's where the opportunity related to prevention really lies. But now, as an industry, what we can do, first of all, we can continue to invest in R&D. Think about today. We are still in pandemic, and I really appreciate whenever we wear masks, because unfortunately, we are still in a pandemic. But what about this event? Would it have ever been possible without pharmaceutical companies investing so heavily in research? And yes, we can invest heavily in research, even on command when there is an emergency like the pandemic, COVID-19, because of IP. That is truly an oxygen for us, because we will never see the return of any investment in a short time frame, but in a longer time frame. So this is an important conditio sine qua non. We can continue to invest in innovation, which is the ultimate frontier for not only for this pandemic, for future pandemic, but it's the ultimate frontier as the true answer to any threat regarding healthcare, also as far as cancer is concerned. Then the second opportunity we may contribute is really sustaining congresses like this one and sustaining the opportunity of having data, so being part of the solution with regards to data. So that is why we are truly sustaining the opportunity to fuel and to realize the cancer registry. Without the cancer registry, we will continue to talk about, something that cannot be measured. If we cannot measure a problem, if we cannot see where the excellencies are, if we cannot have data from all the European members, how can we really move forward? How can we design the best strategies to fill the gaps and to move united? Because as it was cleverly said by Stella Kyriakidis, only together we can move ahead and we can win. At last, as a pharmaceutical companies, there are several initiatives we can really be part of. So I think the most important one are related to continuing to invest in R&D, to invest in partnership with the best minds that can really provide the best solutions across Europe. I'm proud to say we have been nominated in 2022, and for the second time in our history record, in the world list of Fortune for the equitable access to HPV vaccine. It has been amazing, not only how much we have invested in research related to HPV, the opportunity to prevent cancer, but also in the supply, because supply, having the opportunity to provide this vaccine to everyone that deserves this vaccine according to the guidelines, is also very important. And this is another important opportunity that we are offering as a solution. And then we are also advancing patient-centered care in resource-limited communities through navigation programs. We have been very active to that extent as well. And we are supporting and sustaining the annual EU Cancer Forum, because continuing to discuss about the opportunities to progress with regards to cancer inequalities, it's the first step. And at last, we are an active member of FPIA, that is cleverly sustaining the FPIA's weight indicator. But if it is important on the one side to know with respect to every single country, where there are delays with respect to innovation. So counting the months and days since the innovation is available until the innovation is available to every single patient. So counting on this delay. But there is another study that we are funding and we are supporting. It's the publication of Everyday Counts report. This is important because, as a matter of fact, after 12 months of formal reimbursement, so once we are at the end of the patient's weight indicator, we now see that patient access ranges from 22 to 81% across EU member states. So there is another mile that has to be taken, because sometimes the problems is not really in the first part of the pathway, but we have to ensure that every single last mile, last inch, until the very last patient is really into the radar screen. And to that extent also, we need data, collective data, interoperable data we can really act upon, and we can start to share best practices and try to speed up, because every life counts.
Great, thank you. So we've heard, collectively, you've emphasized the role of data. You've also emphasized the power of harnessing the private sector when when there's certain technologies that need to be invented, like in the case of the pandemic. But also, I guess that cancer is an ongoing emergency of the same order of magnitude year on year that COVID has had in the last 2 years. So I want to open this up to the floor. Right, straight away, fantastic, that's good. I don't have to come up with any questions of my own. Thank you, sir. If it's directed at any particular person, please let me know. Or please say it. There was the microphone coming. Oh, should we take that one as well? It's fine. Okay.
Good morning. My name is Mike. I work for a charity trying to create a digital nurse navigator that Christopher mentioned, a website, an app bringing together trusted information service and products for any cancer anywhere in the world. My question is about misinformation. COVID showed us, how much of an issue this can be. I'd love to hear your opinion about how much of an issue it is in cancer care and the best way to tackle it.
Can I take a point of this out of this? Regarding digital, because I think this is an extremely important point that needs to be made. I'm seeing a lot of nice shoes here on stage. Now, if you're an importer here in Belgium and you want to import shoes from Spain or from Italy because I won't say England because you're not in the European Union anymore.
European.
But if you want to import from Spain, you can import shoes from anywhere because it's a single mark. If you want to import a washing machine from Germany or from France, you can do that. And because people buying washing machines want to know what button to press for a spin dry or to wash their silk blouse, the manufacturers of washing machines give you a manual with 12 different languages. But if you want to import a drug from Greece, you're not allowed, because of patient safety, you can't do that because the package is in Greek and the inserts are in Greek. And even worse, if my wife, as an engineer working on a project in Greece and I want to go and live in Athens and I have cancer or I have another disease and I want to access medicines in Greek, I'm at a loss because it's all in Greek, literally in Greek. On the other hand, we live in a digital age. Hands up, who has a mobile in here? Everybody has a mobile in here, yeah? So it's time that we have electronic patient information, e-labeling. I know FPA and the industry want this. Some states in America have it. It's time that we have it. It's time that we have electronic labeling, electronic patient information, which means that if I'm in Greece and I need to access the medicine in Greek, I can scan the barcode, and on my mobile, I have all the inserts and all the information I need to be able to track that. And if I'm a doctor working in Belgium and I want to use an orphan drug for a rare kind of cancer, which is manufactured in Hungary, then I don't need the Hungarian authorities or legislation to change that into Belgian or French or Flemish or whatever. I can do that easily. So I think this is an extremely important point that you make. Digitalization needs to come in our treatment, not just because we have MR-Linacs and because we have digitalized machines, but for accessibility and interoperability of data, and especially to break down the language barriers that we have within the European Union.
And I think Catherine and Dolores both wanted Catherine first.
Yeah, I think it's a great question, and it picks up a few of the things we've said already. So one is the use of digital technologies to reduce inequalities, not exacerbate them, but do it in a way that's engaged with communities to make sure that technology is accessible. You're absolutely right, and COVID really foregrounded the benefits and the risks of technologies and innovation. So we saw fantastic clinical trials using digital innovations to recruit patients direct in their home. I took part in one. You've got a positive test, you register online, someone calls you, you get sent antivirals, fantastic. But masses of disinformation and misinformation, and you see that with cancer, and you see it with every medical condition. If you're diagnosed with a condition, you will reach out for anything, and there's a vast number of sources. So what we need to do, I think, you can't shut that down. You have to amplify the trusted, verified information. And one way to amplify that, I think, is to work with trusted partners. It goes back to the partnership point. So the more you can bring partners together, the more trusted badges, if you like. So Cancer Research UK, we're very trusted in the UK. We provide a lot of information, but we often do that in partnership with other organisations. So you amplify the trust and the evidence, and it goes back to a research base, understanding that research base and bringing it through to the information. Hugely important.
And Dolores, I wondered if you could also address on misinformation. There, I know health literacy has been an important part. Is that
Just
where
an
you-
example on what Christopher was explaining. I was the rapporteur of the European Pharmaceutical Strategy, that now this is the framework, and now it's coming the legislation, the pharmaceutical legislation in the Parliament and in the Commission, and we put this. The drugs, we have to put a QR and giving all the information with the 24 languages of the European Union. Because we are seeking three objectives. First, give information to all patients all around Europe with all the 24 official languages. Second, defend the environment. You know, we're putting paper and more paper in all boxes. So with QR, we're going to waste that. And third, I'm not thinking now with innovative drugs. I'm thinking in generic drugs. You know that sometimes the generic drugs, when they want to participate in a joint procurement in one state member, they have to have 10% of the stockpiling of that drug. Means that they have to have in that language, for example, in Spanish. Then imagine that they are not winning that joint procurement. Means that what we are doing with this 1,000 stockpiling drugs box, waste. So putting the QR, we are achieve three big objectives: information, protecting the environment, and of course, to do not put on the garbage 10% of the drugs. So I think so that the pharmaceutical strategy, it is a good framework, and now let's see what is coming from the Commission in the pharmaceutical legislation. And of course, we're going to work together with the Commission and with all the stakeholders and patients in the Parliament for a good legislation on pharmaceutical.
I couldn't agree more, absolutely, also because the pharmaceutical strategy is an amazing opportunity also to reduce bureaucracy. Because if you think, if we could have, you know, the electronic label, if we could have fewer presentations, because we have to recognize that sometimes also to make more drugs and vaccines available, we have to produce different presentations that really vary from country to country, while if we could harmonize, simplify all the bureaucracy, it could also be an important help in order to reduce time to access to patient, to the innovation, and to the treatment and to prevention, which is always so important. So it could really be a lever to optimize that implementation. What is really important also that the European pharmaceutical strategy might preserve is also the incentives to innovation. And let me highlight that IP is the best incentive, is true oxygen for all those companies that want to continue to invest in innovation. So it's very important that also for the European pharmaceutical strategy, as Stella Kyriakidis was highlighting before, is that we are all part of the same table of discussion, and we can really share and put and offer the best solutions and design the new strategy according to what has worked so far. And pandemic has fundamentally proven that, for instance, IP is working. because we have been able, 250 pharmaceutical companies, to roll up our sleeves and to find the solution. Not all of us have succeeded, but we were in the position to make it happen. So, and to discard what is not working, and I'm referring in particular to bureaucracy, and to start a new age of data, sharing data, possibly without prejudice against everything that comes from private. The only way to succeed is working together.
We'll be exploring some more of those themes tomorrow. You're looking at data in some of the parallel sessions and the power of data. We've got about 5 minutes left, so I'd ask the panel, and I know there's at least 2 questions out there. I don't know if we'll have time for both. Please, panel, keep your answers very brief to the 2 questions that are coming. I hopefully you'll get both in. Please, madam.
Thank you. My name is Katie Raceway, and I work for Youth Cancer Europe. And I have a question for Cancer Research UK. How do you prioritize the clinical trials that you fund or the biomedical research that you fund? The reason I'm asking is because there's a lot of initiatives in Europe where patients are actually in the driver's seat or at the table discussing priorities for research.
Yes,
thank you for that question. So how do we, I suppose you're asking, how do we prioritize which trials we fund and how do we bring the patients into those discussions? So if I think specifically about children and young people's cancers, we have developed a strategy for the research funding where we identify what are the needs, where are the gaps, where are the challenges, and we do that with our patient and public panels. We have both sort of standing panels, groups of patients and public and families and carers who work with us for quite a long period of time. And then we bring in specific groups. We have a sort of call for volunteers to come and help with specific projects. So right from the start of setting the strategy, we have patients and the families involved in that discussion. We prioritize trials in 2 ways. So we'll set a strategy and identify where we think there's a need. And children and young people's cancers is one of those areas we see a big need. There are also cancers of unmet need, like brain cancer, pancreatic cancer, where survival is pretty dismal still. So then within that strategy, we work through a response mode. So we then focus on quality. People make applications to us. We review those and fund them on quality. We also identify through our Cancer Grand Challenges scheme, which we co-fund with the NCI in the US and with individual partners coming to specific challenges. That's another approach where we'll say, what's the really big challenge? And again, pediatric cancers is one of those, and we fund a big Team Science £10 million programme on CAR-T and solid tumour research through that programme. And again, patients are part of that decision-making process. Really quickly, I think when we involve patients, it's not at the very end just saying, what do you think of this trial? Can you look at the information sheet? It's at the very start, what's the strategy? How do we set up a funding call? What are we looking at? All the way through that process. Slightly long, sorry.
Thank you very much. That's great, thank you. We'll have one more question. We've got 3 minutes, and I'm going to keep us strictly to time. So question brief and answers brief, please.
Yeah, hello. So this is a question for Nicoletta. So Jean Hausser, I'm a cancer researcher at Stockholm's Medical University. And you raised important for you to access data. And that's maybe a concern we share, because in research it helps us a lot if we can have molecular data from patients so we can design AIs to find new targets for therapy. So what kind of data is critical for industry?
Pardon? Can you
What kind of data is critical for industry?
Well, for industry, only aggregated data are critical. And for us, it's very important that we have just-in-time information so as we can better serve from what we can, from a research point of view, from a supply point of view, all the citizens and the patients we are honored to serve. So this is, for us, really important. So we are fully in line with the data privacy law, and for us, only aggregated data. But it's really important that these data are quality data. So we are really comparing apple with apples and pears with pears. This is really important. And it's really important to have these data divided, by population groups, because everything that is relevant and everything that can really be at the base of our next steps with regards to innovation, with producing innovation where the big needs are, that's really important for us. And of course, for us, it's very important to preserve patients at the center. So whatever is relevant for patients, it's relevant for us.
Thank you. All right, we're going to have to close up. I will give the floor to our panelists if they any last remarks or observations on this session. But again, please keep it brief. Thank you.
15 seconds.
Yes, 15 seconds. Yeah.
Sustainability. We haven't talked about sustainability. That is the elephant in the room, unless, and the SFPA will tell you the funding gap between the States and Europe is growing. But unless there is a market and unless the prices are sustainable, the markets will collapse. There won't be any scope for research and development of new drugs. So sustainability has to come into the discussion on cancer care every time and in every occasion.
Just the last question to say that I think so that the health data space is the big and huge opportunity for all patients, for all stakeholders, all the industry, and all the 27 state members. And I think so that we have to do it without fear, without mind borders, and without the fear that I'm going to lose the competence in Spain or in Malta or in Italy. No, come on. We are a European Union and we want the best for the patients, and we want a strong industry. We want a strong innovation and research, and we want the best for the patients. So without fear, the times is changing, and the COVID gives a big lessons. So take this opportunity. I think so that, this is my point.
Okay, we're out of time. I think you both had the last... Partnership. Okay, thank you. Good.
And value.
And value. Great. What a wonderful panel you are. Perfect. Thank you very much indeed. Thank you so much. Please, a round of applause.
Thank you.